Hi, I'm Layla, and today I've decided to do my presentation on anxiety disorders in childhood and adolescence. Starting off, anxiety is defined as a complex state of psychological distress that reflects emotional, behavioral, physiological, and cognitive reactions to threatening stimuli. Anxiety disorders, on the other hand, are mental health disorders characterized by feelings of worry, anxiety, or fear that are strong enough to interfere with one's daily life. It is normal for all children to feel some level of anxiety. So, when asking the question, what is considered normal anxiety in children, we are differentiating the level of anxiety that is normal and the level of anxiety that is considered strong enough to be classified as an anxiety disorder. This is maladaptive anxiety. And anxiety becomes maladaptive when it is intense and out of proportion to the threat that triggered the anxiety response, when it is chronic, and when it interferes with the person's ability to perform daily activities. In the DSM-5, there are 7 classified anxiety disorders that can be diagnosed in children, adolescents, and adults. This includes separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder, panic disorder, agoraphobia, and generalized anxiety disorder. Looking at the prevalence of anxiety disorders, 20% of children will develop an anxiety disorder before adulthood, while 5% of children and adolescents have an anxiety disorder at any given time. There is also higher amounts of adolescents with anxiety disorders than there are younger children. Additionally, anxiety disorders are thought to be the most common diagnoses in children and adolescents. The lifetime prevalence of any anxiety disorder is 28.8%, and approximately 13 out of 100 children and adolescents experience an anxiety disorder within the median age of onset at 11 years old. Within each anxiety disorder, the prevalence varies. The prevalence of separation anxiety is 0.7%, 0.8% specific phobia, 0.8% social anxiety, 1.5% of generalized anxiety disorder, 1.1% of panic disorder, 0.5% of agoraphobia, and 0.18 to 1.90% in selective mutism. Getting into each anxiety disorder, we're starting off with separation anxiety disorder. This disorder is characterized by an excessive anxiety a child feels when leaving their caregiver and when the child fears that misfortune or harm will happen to themselves or their caregivers during the separation. Onset of this disorder is between 7 to 9 years of age, and its causes include insecure ambivalent attachment, which arises when caregivers provide inconsistent responses to a child's needs. This causes the child to have a desire for closeness and intimacy while also having a fear of abandonment and rejection. This could also be caused by parents modeling controlling, overbearing, and worrying behavior. Features of this disorder include clinging to parents and caregivers, fear of separation, crying when separated from parents, refusing to go anywhere without parents, worries about losing parents, refusing sleepovers away from home, avoiding activities without parents, refusing to sleep alone, refusing to go to school, and tantrum while separated from parents. We also have selective mutism, which is a consistent failure to speak in specific social situations where there is an expectation to speak despite speaking in other situations. It is important to point out that this failure to speak is not attributed to a child's ability or comfortability with language or any communication disorders. The onset of this disorder is between 2.7 to 4.2 years of age and is caused by an interaction of genetics, temperament, and early social learning. Features of this disorder include being tense around unfamiliar people, nonverbal communication to express needs, fearful of birthday parties or family gatherings, inability to speak in certain settings, shutting down around strangers, uncomfortability with expectations to speak, and being socially awkward and shy. Moving on to specific phobia, this is a marked fear or anxiety about a specific object or situation that almost always provokes immediate fear and anxiety. Most phobias fall into the categories of either animals, natural environments such as thunderstorms or water, blood injections and injuries, which can include fear of needles and seeing blood, specific situations such as airplanes, elevators, or enclosed spaces, or other stimuli, which can include fears of choking or of certain characters. Causes of this disorder can include classical conditioning, which is when an individual pairs the feared object with an unpleasant stimuli, observational learning, which is when a child watches someone else react with fear towards certain objects, events, or situations. or through informational transmission when the child develops the phobia by talking to others or hearing other people's experiences with it. Phobias are characterized by intense and immediate reactions, panic in particular situations, difficulties breathing, intense sweating, avoiding feared locations or objects, being powerless to control fears, and anxiety when exposed to a certain object. Social anxiety is a marked fear or anxiety about social situations in which the young person is exposed to possible scrutiny by others and fears that they will act in a way or show anxiety symptoms that will be negatively evaluated. Causes of this disorder include genetics, high levels of behavioral inhibition, parents who are controlling, overprotective, hostile, and critical, and parents teaching their children to be anxious and avoid emotionally charged discussions. Social anxiety is characterized by avoiding social situations, fear of meeting new people, fears reading out loud in class, freezing up around others, refusing to go to school, fear of being judged by others, and intense anxiety in social situations. Panic disorder is characterized by the recurrent unexpected panic attacks that are not restricted to a particular situation. There is also concern about when future attacks will occur and a change in the child's behavior related to the attacks. The onset of this disorder is between 15 to 19 years old and is usually caused by a biological predisposition towards anxiety sensitivity, which is when we perceive anxiety symptoms as extremely upsetting and aversive. Finally, we have generalized anxiety disorder, and this is an excessive and uncontrollable worry about a number of events or activities that is characterized by worry rather than fear or panic about future misfortune. This disorder is usually associated with at least 3 symptoms, which can include muscle tension, difficulty concentrating, and sleep disturbance. The onset of this disorder is between 8 to 10 years old and can be caused by what is explained as the cognitive avoidance theory. This theory describes worrying as being helpful for people with this disorder to avoid unwanted emotionally and physically distressing mental images. Features of this disorder include the inability to relax, clinging to family members, having constant thoughts and fears, being easily startled, reassurance seeking, worrying about friends and family, and refusing to go to school. Those who have this disorder are differentiated by those who do not by being described as having a greater number of worries, rating worries as more intense or distressing, and spending a greater duration of their day worrying. When talking about what causes anxiety disorders, the 2 strongest predictors first include inhibited temperament, which is the tendency to withdraw, avoid, or fearfully respond to a new situation. Having this inhibited temperament makes a child 7 times more likely to develop an anxiety disorder. The second strongest predictor is having a parent with an anxiety disorder, which has been shown in studies that suggest that heritability rates explain between 25% and 50% of child anxiety symptoms. Parental involvement and control also plays a role in the development of anxiety disorders, as it is both elicited by a child inhibition and anxiety and influences development. Anxiety disorders can also be caused by parents modeling fear behaviors and having a transference of fear information. Effects of parental behaviors on anxiety disorders vary based on the child's characteristics, such as child age or stage of development and their temperament. It is possible that life events and peer relationships may also play a role in the development of anxiety disorders, but there has not been enough research to make this claim. In the assessment of anxiety disorders, these disorders are assessed using a multi-method and multi-informant approach. One method of assessment is interview schedules, and these are structured diagnostic interviews that provide a comprehensive assessment of anxiety, including symptoms, severity, and interference, using independent information from both the parent and the child or adolescent. Regarding diagnoses and treatment options, these interviews consider all anxiety disorders and any other related or comorbid disorders that the child may have. Another method of assessment are questionnaire measures. Diagnostic interviews are typically supplemented with psychometrically reliable and valid questionnaire measures from multiple sources to assess anxiety symptoms and/or impairment. Some anxiety disorder questionnaires include Spence's Children's Anxiety Scale, Screen for Child Anxiety and Related Emotional Disorders, and the Multidimensional Anxiety Scale for Children. Finally, we have observational measures, which are infrequently used outside of research settings, but can be used to determine the level of fear or anxiety experienced when the child is exposed to threatening stimuli. This includes behavioral approach tasks, which involves the child taking steps of increasing difficulty towards a feared object or situation in a controlled environment. A commonly used therapy that has been effective in treating anxiety disorders is cognitive behavioral therapy. CBT includes application of exposure to enable children and young people to confront fear situations in order to develop new learning about what really happens when they enter anxiety-provoking situations. Exposure is typically accompanied by cognitive restructuring procedures to help children identify and challenge negative automatic thoughts. CBT also includes other forms of skills training, such as relaxation, social skills, and problem-solving training. The goal of CBT is to help the child recognize the cognitively distorted thoughts, to reality test these thoughts, and teach the patient skills to challenge irrational thoughts and replace them with more rational ones. Although CBT has been shown to be effective for treating multiple anxiety disorders, recent studies have shown that children with social anxiety disorder tend to benefit less from generic CBT approaches. A recent study has shown the Cool Kids Social Program as an effective treatment for reducing severity of social anxiety disorder symptoms. The Cool Kids Social Program is a cognitive behavioral treatment program designed to address the theoretically proposed mechanisms involved in the maintenance of social anxiety, including attention training to reduce self-focused attention, video feedback to reduce safety behaviors, and behavioral experiments with a focus on exposure to cost. Although not typically given to younger children, older children can also take medications in order to treat their anxiety disorders. Selective serotonin reuptake inhibitors, also known as SSRIs, are safe and effective in reducing anxiety in children and adolescents. CBT and medication treatments can also be combined, as studies have shown that combined treatments produce more than 20 to 25% greater improvement than CBT alone, SSRIs alone, or placebos alone. Future considerations for anxiety disorders can include finding more effective treatments beyond CBT and medication, and finding more personalized treatments for different anxiety disorders, such as what was done for a social anxiety disorder. There could also be efforts done in finding prevention and early intervention strategies for at-risk children. This could potentially help in stopping the development of anxiety disorders and saving children and their families from any distress that the disorder may cause. Future research could also utilize advances in technology to increase access to treatment, deliver treatment, individualize treatment, and address issues in traditional treatment approaches. Finally, we can increase attention to developmental issues and consider potential variations in treatment delivery as a function of development, as previous research has not shown very much how variations in treatment might compare among different age groups. These are my references, and thank you for listening.